Yeah.
Can you imagine? Next time we'll be telling, my grandkids, those were the days.
Those were the COVID days.
Yeah, we can't shake hands, we can't hug, we can't so many things. We wear masks, I can't recognize my friends. Yeah, seriously, some not friends, some patients. I felt very embarrassed because sometimes I walk in the malls, then they come out and say hi and everything. I think I'm quite easily recognizable. My hair is all white. But it's so hard for me to recognize them when they're wearing their mask. It makes it so much difficult.
Some more we have so many patients, ma.
Yeah, last week I had to say hi to somebody and we actually chatted for a while, and I frankly have no idea.
Until the end of the conversation.
Until the very end, then my son was next to me. He's like, "Who is that?" I said, "I have no idea." I vaguely remember what he has, what the struggles that he had, all that. But if you ask me his name or what he looks like,
you can't put a name to his face, right?
I just couldn't. Oh yeah, thanks for helping out in that app.
Which one?
Our COVID task force and.
Oh, no problem.
Yeah, quite a lot of. I haven't been very active there, lah. Usually they'll ask some things and just to verify or clarify. That's it. But I haven't been active, providing consulting and all that.
But Tuanku Jafar's taking in all categories up to stage 5 lah.
Pardon?
Is Tuanku Jafar taking up all the categories also?
Yes, we are because we actually opened up Rembau Hospital and Tampin Hospital as COVID. So we sort of shun the more the lighter or asymptomatic cases over there.
Right.
We handle the more serious ones. Yeah. Is my connection okay?
Yeah, your connection's fine. No worries.
Just get worried that the internet is always a problem, no? Yeah, especially when you teach.
You're in the office?
No, I'm actually at home. Today is a public holiday, so.
Oh yeah, I forgot.
Yeah, so I'm at home.
How do you get that nice background?
I just put it up in Zoom. I just downloaded. I mean, I not downloaded. It's just one of the photos I took. It's in Kuching, and then I just put it as my background.
I see.
Kuching is not a good place to go now. It's very, very badly flooded.
Yeah, definitely.
So let me ask you, what do you see on your screen? You're seeing your name there as well, right? On the top left corner, do you see that or no?
Sorry, Prof, you were saying?
No, I'm asking, what do you see on your screen? Do you see my slide?
Yes, I see your slides and I see your face.
Okay, and do you see your own name at the top corner or you don't see that?
No.
Okay, because I'm not aware of what you are seeing. What I'm seeing is totally different from what you're describing to me.
Oh, what are you seeing?
That's why I need to know. This is what I see on my screen. I sent it by messenger, so.
Sure.
So I can see name up there, M. So it's not.
Oh, I think that means you will be if you see the one on the top left, I think that would be the one who's going to be talking to you. I mean,
yeah.
Whoever's microphone is on, then.
But you don't see it on your screen, correct?
No.
Good. Because that would be very disruptive if it's on everybody's screen. So I was
no.
And that top bar also you don't see it on your screen.
No, it's just your slides and your face on the top right corner.
Okay, that's great. Yeah, that's what I was asking Afiq just now. Yeah. What exactly does he see? I was quite worried because I was thinking, how come the names are there, then the bar is there? So I'm the one who have to start the webinar, is it? Button that start webinar there.
Yeah, any one of us, when it's 3.
All right. Okay. There's 17 minutes. No, there's 17 minutes more. Maybe you
Sure.
can take a break or something. Come
Sure,
back.
sure. No problem. See you in a bit.
Yeah. Okay. Bye.
Shall we start the webinar to let the participant join?
Is everyone ready?
There's another Dr. Mabel. Is that?
Oh. Who is the other Dr. Mabel?
Who's the other Dr. Mabel?
Oh no.
Siapa tu yang guna Dr. Mabel punya link?
I also tak ingat who I sent to already.
Dr. Mabel is too famous.
Hey, Afiq, I also forgot to remind you to send email reminder. Ada tak? Monday and Wednesday.
Ada.
Ada. Thank you.
Another 4 more minutes. Okay, start. Is Prof. Adeeba ready? I think we're just waiting for Prof. Adeeba. Once Prof. Adeeba is ready, we can go.
Sorry, everyone. Tell me when we're ready.
Okay, we shall start now.
Okay.
Good afternoon, everyone. Thanks for joining us for the second week of the ID month. Today's topic will be on the science behind U equals to U by Prof. James. Before we start our webinar, I would like to announce a small change in our topic for the fourth week. Initially, it was supposed to be a management of MRSA. Now we have changed it to management of COVID-19. So today's speaker is Prof. James. The chairperson is Prof. Adeeba. Prof. Adeeba, the floor is yours.
Okay, thank you very much, Dr. Ang, and good afternoon, everyone. Thank you to the Academy of Medicine for hosting this very important weekly webinars. I think this month's focus is on infectious diseases. So we're very privileged to have Prof. James Koh from IMU this afternoon to speak to us about important and controversial topic known as U equals U, or translated, it's undetectable equals undetectable, and why it's important and why it's controversial. Now, James is been a long-time colleague, having trained at UMMC in infectious diseases, and then went on to greener and better pastures at IMU. But obviously, we've all kept in touch. The ID fraternity is very small, and has really gone on to do bigger and better things at IMU, and is now the Associate Dean of Academic. And I know, you know, from my conversations with James and from his Facebook postings, that he is very passionate about teaching. So today is fulfilling part of that passion, and really also passionate about community care and looking after people living with HIV in general. So we look forward to hearing from James the updates on HIV prevention and treatment around the concept of U equals U. So over to you, James.
Thanks, Prof. Dato, Dr. Adeeba. I'm very privileged to be in the same panel with you. Hi, everyone. Good afternoon. I'm going to share some evidence, not some evidence, all the evidence behind this concept of U equals U. As what Prof. Adeeba said, it's a very controversial subject when it was first mooted about 20 years ago. But since then, it has become one of the strongest tool that we are using as ID physicians and NGOs and advocates everywhere in the fight against HIV, right? Another virus. I know we are all overwhelmed with COVID at the moment, but it's good to take a break from COVID and listen to something else for at least an hour. So thank you for your time, and I'm just going to plow on with the presentation. This is the content of what I'm going to share with you today. I'm going to explain what is U equals U, and for the benefit of some of the people here, they may be students, they may not be familiar with terms used in HIV medicine. So I'm just going to maybe spend a little bit of time to explain some key terms and definitions. And then we're just going to go a little bit into the history of HIV, a very short one, and that will form a foundation of what I'm going to talk about for the remainder of the time. Right. So U equals U, as what Prof. Adeeba said earlier, it just means, if you expand it, it means undetectable is equals to untransmittable. So this term was officially launched in 2016, although the concept has been there for more than 1.5 decades. It just is based on this statement: a person living with HIV who has undetectable viral load does not transmit HIV to their partners. So when you hear something like this, when I heard this statement about 2 decades ago, it stunned me because I thought this would be something impossible. And my first reaction would be, Chinese being Chinese, sure, boy, are you sure or not? Really, that was my own reaction at the time. And I suspect for many of you here today, maybe even your first reaction. So I'd like to share the evidence behind this, this concept to get us all on the same page, and then maybe we could do more work or help to advance the preventive measures to reduce HIV infection in our community. So this U equal use concept is endorsed by at least more than 350 organizations in the world, right, including IAS, UNAIDS, and BIVA. Right? So these are some key definitions for those who are unfamiliar. When I say viral load, it means a measure of the amount of HIV in the body. When I use the word viral suppression, it means that when antiretroviral therapy is taken long enough, it reduces the ability of the virus to replicate in the body. So that's what I mean by viral suppression. And this word undetectable viral load basically means somebody who is on antiretroviral therapy for sufficient amount of time until the viral level in the body is so low that when we use our standard tests in the lab, we can't detect it in the blood, right? So that means undetectable. It doesn't mean that the virus is not there, it's just that we cannot detect it. Right? Untransmittable means HIV cannot be transmitted through sexual transmission, at least in the context of my talk today, is through sexual transmission, not talking about any other means of transmission. And we take the absolute number of less than 200 copies per mil as the definition for untransmittable or viral load level, which is undetectable, right? Briefly, HIV is not that old, or some people say it's quite old also. 1981 was when it was first noticed in 5 gay men in Los Angeles. They presented with pneumocystis pneumonia. And in California, there were some reports of Kaposi sarcoma in young men in 1981, right? In 1982, the word AIDS was first coined by CDC. 1986, so 5 years after it was first reported in US, HIV arrived on our shores, Malaysia. Right? And the following year, the first antiretroviral drug, AZT, zidovudine, was approved as a monotherapy. And in 1988, WHO declared 1st December as the first World AIDS Day. So since then, every December, I'm sure if you work in a hospital, there will government hospital, there will be celebration, or rather remembrance as 1st December as the annual World AIDS Day. With regards to antiviral therapy, ART, when AZT was first introduced, but there was a lot of euphoria and all that. At the time, AZT was quite expensive. When I read the history, it cost about $3,000 per year. Right, there's quite a lot of money at the time, right? And I thought it was something that was breakthrough, and people started getting well on just AZT. But eventually, not long after, you notice that the patients start to relapse. They get back to the immunosuppressed status that they were in before they started taking the medicine. So it's obvious that monotherapy doesn't work. Right? In 1995, Merck and the National Institute of Allergy and Infectious Diseases, they started a trial using a 3-drug combination, and it proved to be very successful. It was able to suppress HIV, and people started getting well. Their immune systems recover, and patients, the lifespan of patients began to get longer and longer. And since then, we have new ARTs coming in. So the concept of a combination drug is known as HART at the time, highly active antiretroviral therapy. And then suddenly we changed it to CART, combined antiretroviral therapy. And we got a bit lazy now, and then we call it ART now, ART. It sounds good, also very cool. Right? So in 1996, they announced this breakthrough using a 3-drug combination in the treatment of HIV. And this concept has held, it stood the ground over the years. And until today, we still use combination drugs in the treatment of HIV. So this point in 1996 is probably the time where the concept of U equals U became a reality. Although at that time, probably nobody realized it, right? So how do we approach to solve a problem scientifically? Right? First, we observe something, and then we decide whether 1 or 2 hypotheses will explain what we observe. Right? Then we test that theory or theories that we have in a carefully crafted experiment. And following, when we get the results, we can redo it again, and the results will be the same. Means it can be repeated. And these 4 steps are basically the foundation of all clinical trials. We observe something, we have some hypothesis, we test it, we get the result, and redo it, you get the same thing again, and it's repeatable. And then we say, yeah, that's probably solid. That's good evidence. Right? So I'm going to present to you 20 years of evidence for U equals U, and it covers 4 different types of evidence, from observational studies, from randomized trials, systemic reviews, and expert opinions. Right? So in the in the late 90s, the early 2000s, these 4 studies here became the sort of the cornerstone, the foundation of what all the other research subsequently were built upon. So you look at the first study that was in 1998 in the San Francisco cohort. It's a very small group. What they did was they were looking at HIV positive women on triple ART during pregnancy, and they found that mother to child transmission was reduced to almost 0. Right? This is 1998. This is a long time ago, and this is that key concept that shows that we are able to prevent infected mother from passing the virus to the child if we use ART when they are pregnant. Subsequently, DHHS guideline had used some expert opinion, and they advocated at the time that it is theoretically possible or plausible to reduce the transmission risk if ART is started early. Right? So that was that time there isn't any trials, but it's an expert opinion. They think that, well, if the patient is on ART, quite likely we will be able to reduce transmission risk. Now, the next study is called the Rakai study, quite popular or quite famous at that time. And it is a prospective observational study in about 400 sero-different or sero-discordant couple. What do I mean by sero-discordant? It means a couple, one of them is HIV positive and the other one is HIV negative. Right? And they have used this very loose criteria of viral load less than 1,500 copies. That's really high by today's standard, but at that time, 1,005 copies. And they found that in these 400 couples, there was zero transmission when the viral load is less than 1,500. So it's a 2,000 study, quite long ago, but definitely proving something quite remarkable. Yeah. Now the Spanish study in 2005, again another prospective observational study. This time in about 400 heterosexual discordant couples. They are enrolled over the period of 4 years, and where they looked at the negative partner becoming HIV positive. So they also found that zero transmission occurs in HIV positive partner, where the HIV positive partner is on ART with undetectable viral load. But they also caution that there should be good adherence and there should not be any sexually transmitted illnesses at that time, right? So these are the baseline sort of foundation kind of study that the subsequent studies were built on. And then in 2008, now this is the statement that really stunned me. I still remember when I first heard this statement. That's my sure ball moment when I was in UM. I was working there as a trainee ID physician, and when I first heard this statement, I was really stunned. It's almost like, you have a toy. I remember when I was a small boy, I was given a toy gun by my auntie, and I played it for the longest time. And we don't read instructions, guys are all like that. So I don't read the instruction of the toys, and I just play with that toy gun for the longest time until one day I found out that that toy gun is capable of so much more. I could detach one of the parts, put in some bullets, plastic bullets, and I could shoot the bullets really, really far if I had done that step. I did not realize it. I have held on to that toy for the longest time, and I have not learned that what I have in my hand is capable of so much more. So when I first heard this statement, it stunned me because we have been using antiretroviral drugs for the longest time. It never occurred to me until that day that what I've been prescribing to my patient does so much more than just getting them well, right? So this statement is released in Switzerland, where it was in response to this criminal law in Switzerland. In Switzerland has one of the strictest laws governing sex in Europe, right? Over there, it is a criminal act for somebody who is HIV positive to have sex with somebody who is HIV negative, even when there is consent, right? So it's a very strict law, and a lot of cases have been prosecuted through this very strict law. So this statement was in response to this strict criminalization of sex between HIV positive and a negative partner. I highlighted in red here. It basically says an HIV positive individual on effective antiretroviral therapy who have had an undetectable viral load for at least 6 months and without sexually transmitted infections are sexually non-infectious. So when I heard this, so boom, I now have a drug that not only makes somebody better, it actually, make that person so-called safe, unable to transmit the infection to someone else. All right. So just to go into a bit of detail here, it was just the first declaration of the UN U equals U concept But at that time, that's why Prof. Adeeba said it's very controversial, because people, it takes a bit of convincing to hear something like that. There's like, where's the evidence? I want to know what's the evidence, right? But because at that time there were no randomized clinical trials to back this up, they were just looking at small studies and they came out with this statement, right? But I tell you, after more than 1 decade, there have been no cases have been published that could refute this Swiss statement. And since the publication of this statement, the criminalization law in the Switzerland has been reduced significantly, right? And now people with HIV are no longer prosecuted under that law. Right? So this is a pivotal study. This is in 2011, HIV Prevention Trials Network Study 0.052. And this has been hailed as the breakthrough study or research of 2011. Right? In this study, it observed, or rather research into early versus delayed antiretroviral therapy. At that time, CD4 less than 350, and about more than 1,700 serodiscordant couples, and 98% of them were heterosexual in South Africa, Latin America, and Southeast Asia. They were all provided with condoms and info on reducing risk of HIV. There were 39 transmission reported, out of which 28 were linked to the enrolled HIV positive partners. And out of this, 27 out of 28 were in the delayed ART group. Right? There's one single transmission in the early ART group occurred weeks from starting therapy, which means at that time the viral load would have been still high and detectable. So the conclusion of this study was there was 96.4%, we usually use the number 97% reduction in HIV transmission if we start ART early, right? And this study was subsequently stopped prematurely because the evidence is so strong that they thought it is not ethical to carry on with it, and they put all the participants on ART. And this is the first evidence of treatment as prevention in the HIV prevention strategy that was shown in an RCT, right? At that time, the durability of finding and precise correlation of lack of transmissibility with undetected viral load was not possible, because viral load at that time is not really widely available. Even in Malaysia itself, only in the last decade or so, we are able to do viral load quite easily. And before that, it was quite tough to get the viral load, right? But since then, 5 years follow-up of that of this study has shown that the finding is valid, right? The next study, the important study, is called the partner study. It started in 2014 and finally concluded in 2016. This was carried out in 14 European countries and on 1,166 couples. And they looked at risk of HIV transmission via condomless. Now we say condomless. Now, last time the word was, how do you say it? I can't remember what's the word now. But now the current word is condomless, okay, or without barrier or something like that. I can't remember. Sexual intercourse in 1,166 HIV discordant couples, where the HIV positive partner is receiving ART and have achieved and maintained viral load of less than 200. So this is much stricter than the Ugandan study where they use 1,500. So they analyzed the results from 888 couples, very long number for Chinese, out of which 340 of them are gay couples. And they found there is no linked HIV transmission in 58,000 condomless sexual acts. That's a lot of sex actually, right? And of this, 36,000 of them were reported by the heterosexual couples, right? There were 11 new infections, but none of them were linked to the enrolled index partner. When I say linked, means it's a phylogenetic study. Means they take the blood of the person who was infected, take out the virus, look at the genetic and also compare it with the enrolled partner. They're supposed to enroll together, and they find that the virus is not the same. That means the infection was, they got the infection from someone else other than the index partner, right? So 1/3 of the sample population were MSM, means men who have sex with men. So considered too small to make any solid or strong recommendation at that time, right? There were no HIV transmission in 91 couples where they had the STI. So again, this is a new finding compared to the one I told you earlier, where they caution against having STI. What this study proves is that even with the presence of STI, with ART and undetectable viral load, there's no transmission. The next study is called Opposites Attract in 2017, fairly recent. And this is solely in gay male couples, 343 of them from Australia, Thailand, and Brazil, where 80% of them are HIV positive partners were on ART, out of which from this 80%, about 80% of them have suppressed viral load. And they found that there was no linked HIV transmission after 16,800 acts of condomless anal intercourse over 588 couple years of follow-up, right? During which time the partner with HIV was on ART and had viral load of less than 200 copies. So there were 3 new infections at that time, but again, none of them were linked to the enrolled index partner. So this is a first study to provide data about risk for gay men. So we had strong evidence for heterosexual couples. Now we have strong evidence for gay couples as well. In Partner 2 study, which is an extension of the earlier study, Partner 1 study, what they did was 400 something of them from the Partner 1 study had continued on to Partner 2 study, and they recruited another 400 over new gay couples, and they followed them up. And they were roughly around 77,000 condomless sexual acts. And again, they found that there was no linked HIV transmission. Right? There were 15 HIV negative men who did become positive, but again, their infection was not linked to the enrolled HIV positive partners. Right? So we have really strong evidence from 4 studies that shows that regardless whether it's heterosexual or same-sex couples, the transmission of HIV is reduced to 0, provided that the couple or the one who is HIV positive is on ART sufficiently long enough to have a viral suppression to viral load of less than 200. So quite strong evidence. So I'm going to, over the next 2 slides, I'm going to show you some more, evidence that helps us to formulate how to manage, how to use this concept of use equal use, right? This study is called Partners Prep Trial in 2016, and this is in almost 5,000 heterosexual HIV discordant couples in Kenya and Uganda. It's designed to determine the risk of HIV transmission, and they have used quite a strict viral load suppression criteria of less than 80, right? And they follow up these couples, they put them on ART, the HIV positive partner is on ART, they follow up at, at 0 months, at 6 months, and beyond 6 months. So you can see that here that the HIV incidence prior to initiation of ART was 2 per 100 persons year, 2, right? 1.79 when they were on ART between 0 to 6 months. And if they are on ART for more than 6 months, it's 0. So again, now we have evidence to say that if the person is on ART for more than 6 months, so this concept of U equals U is very dependent on the person adhering to ART for more than 6 months. Right? There are 2 other studies. I remember these 2 studies because I went for a talk and it was the speaker was going on about smart and stop and start and stop. It was quite funny, but basically just to summarize for you, these 2 studies just wanted to test what will happen if a person is on ART and the viral load is suppressed. Can we stop the ART and see whether the virus will rebound or not? Or can we just give them a drug holiday? Maybe take ART for 2 months and stop taking for 2 months and carry on for 2 months, something like that. We're just trying out various strategy because being on pills for lifelong is really quite burdensome for patients. And the result of these two studies show that the moment we stop ART, there is a viral rebound within 2 to 3 weeks. Meaning that what it's saying is that patients who started on ART will have to be on ART for the rest of their life to suppress the virus. There's another systemic review in 2018, just a couple of years ago, 3 years ago, and this is on 12 recent clinical studies, and again showing negligible risk, zero transmission for 100 person years in HIV sexual, among HIV discordant partners, where the partner with HIV adheres to ART, again maintains a viral load of less than 200. And this is measured routinely from every 4 to 6 months. Incidentally, in the same year, Malaysia achieved a significant milestone. So 20 years after the first study, the San Francisco study, right, shows that reduction of transmission from mother to child by using ART. Malaysia, I think this is something that we should be very proud of. We were presented with this validation certificate for the elimination of mother-to-child transmission of HIV and syphilis. We were the first country in the World Health Organization, Western Pacific region, to be certified for achieving this milestone. So it's something that we are very proud on. In Malaysia, the antenatal care is one of the top, I think, in the world. Right? We test every mother, register them early. We test everybody for HIV and other STDs, and if detected, we treat the mother immediately, and we have achieved zero transmission. So what are the T and C's of U equals U? Basically, to achieve this U equal U status or condition, the person has to be on ART lifelong. They have to take it for up to 6 months. Once they achieve, then they have to continue to adhere to the ART, right? And the viral testing for us who are managing the patients have to be tested. The patient have to be tested every 3 to 4 months, right? And to for them to ensure that they are virally suppressed. In this definition, is less than 200. But in Malaysia, when we do our tests, even in my clinic, our machine is so good that we detect the level is so much lower than this. It's less than 20. We call that undetectable. Right? To put that into a diagram, this is what we mean. Right? So take a pill every day. We tell the patient, take a pill every day for 1 to 6 months to achieve the undetectable viral load. And then you take it for a further 6 months to maintain this undetectable viral load. And then we tell them, now you are effectively at no risk of transmitting HIV to your sexual partner. Right? This is the T and C of U and U. U equals U. Now, in what condition is U equals U not recommended? There are 2 conditions. So far, the data is, all the research has been focusing on just sexual transmission. So we can't confidently say that injecting drug users will be protected, right? If this with this concept or with this strategy, and also in breastfeeding mothers, right? Because there have been cases reported that mother, although had negative or undetectable viral load, they still managed to pass the infection over to the child via the breast milk. So U equals U is not recommended in these 2 cases. So what are the implications of this evidence that we have? Now, to the person who is living HIV, I think for them would be very liberating. If we could spread this news out, it will become an incentive for many to start seeking and initiate and also adhere to their treatment. And for many, it would remove a lot of fear and guilt, because even in my patients, many of them suffer from severe guilt and fear that they would transmit or pass the infection to their loved ones. It will reduce and eliminate internal and external stigma. Now, in the community, this will become a powerful tool. U equals U concept is a powerful tool to go and tell them, look, now we have a drug that not only makes you well, it also make you uninfectious, you can't spread it out to people you love, to the people in the community. So it's become a very powerful tool that we can use. And in the legal aspect, just like in Switzerland, it would mean that with this concept, we can advocate or fight and say, you cannot criminalize people with HIV positive from having sex with somebody who is HIV negative with consent, and you cannot criminalize that person just because it's HIV positive, because that person is on ART and he is undetectable. In fact, in Switzerland, up to now, there are at least 2% who has been freed, and they cannot be prosecuted because of this concept and because of the Swiss statement. So the science is solid and it's very convincing. It's 4 studies. If we combine them, it essentially shows there's a zero linked transmission after more than 100,000 condomless sex. If I divide that by 365, it's like there's a lot of sex between heterosexual or male to male serodiscordant couples, right? Provided that the partner living HIV has durably undetectable viral load. So what can we do? This is a statement which I liked very much. It says, not sharing this evidence with your patient is withholding data that are life-saving, life-prolonging, and stigma-erasing. Right, thank you. That's the end of my talk for today. I hope you are convinced with me, and I hope, as scientists, as doctors and scientists, we always say evidence-based medicine, and that's what I teach my students. And the evidence for this concept is strong, is solid, and is valid and reliable. Thank you.
Thank you very much, James, for that really brilliant summary of all the important trials that have gone on to prove the concept of undetectable equals undeniable. Untransmissible. Undetectable equals untransmissible equals undeniable. Which forms a very important basis for the calls to end AIDS, and really together with this push to get as many people treated as quickly as possible, to get their viral loads down to undetectable, plus the scaling up of pre-exposure prophylaxis for those who have not yet been infected. We really are looking at the possibility of ending HIV/AIDS, perhaps not in 2020, well, not in 2030. In some countries, that possibility is looking quite real. I think in places where they've achieved the 90-90-90 or 95-95-95 goals, of having 90 or 95 people as close to 90-95% of people knowing their HIV status, and of those 90% people are on antiretroviral therapy, and then the 90-95% of people have undetectable viral loads. Those are the targets to achieve ending the AIDS goal. In countries and jurisdictions where this has been achieved, we're seeing low incidence of new infections, especially coupled with, as I said, widespread use of pre-exposure prophylaxis. So this is very clear science. In HIV, I guess it's taken a long time to get us here. I was just before the session, I was sharing with James how really the science was there in terms of the ACTG 076 in 1998 that proved that if mothers receive antiretroviral therapy, the chances of their babies being born with HIV was very low. Of course, that was coupled with treatment in labor and also post-exposure prophylaxis to the babies. But still, it took us another 2 decades to get here. Thank goodness with COVID, we work a lot faster. Otherwise we'd be in a bigger mess. But so here we are. So there are some questions in the chat group, James, for you.
Yes.
Certainly we welcome. There's 126 participants this afternoon, that, as far as I can see on this Zoom chat. So there are some questions in the Q&A and also in the chat group, James. So question from Dr. Tai: how do you counsel serodiscordant HIV couple who wish to start a family? Can they have regular condomless sex, and how soon can they have condomless sex after undetectable viral load?
Okay, thanks.
And the second question is related to that as well. Can a person living with HIV with suppressed viral load and discordant couple have natural conception and normal delivery?
Yep. Thanks, Prof. Adeeba. If you ask me this question 2 decades ago, I think that time they will say, no, don't have sex, don't marry, don't start a family. And unfortunately, until today, that advice is still being given to some couples, which is very unfortunate. I think we need to move on from 2 decades ago. At 2 decades ago, probably quite valid, because at that time we didn't have a lot of evidence to show the ART can work. And so at that time, everybody says, yeah, so let's not marry, let's not have children, let's not do many things. But now 2 decades forward, I see patients in my hospital, and I have about 500 over patients now, and there are quite a number of serodiscordant couples in my clinic as well, and they all they have children, right? And none of the children are. That's one of my greatest disappointment, that I cannot carry the baby, have a selfie, and then post on social media or something like that, because the stigma is still so great. But I can tell you that none of the babies are infected. And none of the partner who is negative is infected as well, despite the condomless sex. So how do you counsel serodiscordant couples who wish to start a family? And will tell them, yes, it is very much possible now, right? With the terms and conditions that I have mentioned earlier, meaning that the person who is HIV positive will have to be on ART, have to be very adherent, have to follow up, have to have viral load done regularly, and it has to be maintained more than 6 months, and thereafter still adherent, still being followed up. And then I'll tell them, just go on, have sex, and they do, and they have condomless sex, and they have children who are perfectly healthy, uninfected, and the partner is also uninfected. So coming to the second question, can a person with living HIV, suppressed viral load, and serodiscordant couple can have natural conception? Naturally. In fact, if you look at the guidelines nowadays, we advocate when there are no contraindications for natural conception and normal delivery. Terms and conditions apply again. When there are no contraindications to a normal vaginal delivery, then definitely yes, it can be done. Yeah. What percentage of patients achieve so low viral load after 6 months of treatment? In my experience, if they are adherent, everybody reaches 6 months of, even before 6 months, they will reach undetectable viral load. If I am a HIV positive surgeon, well controlled, do I have to avoid operating? If I'm allowed to operate, do I need to disclose? Tricky, because today's topic is about sex, yeah, so it's a bit probably not in the correct forum, but yes, if you are I think Malaysian guidelines so far as I'm aware, and Prof. Adeeba can correct me if I'm wrong, that we treat even doctors who are HIV positive to become virally suppressed with an undetectable viral load. And our guideline, as far as I can see, do allow, if you look at the at least the MMC guideline that I have, that is quite old, but there are 3 categories of operation that can be done. That there are 3 categories of say procedures that someone can or cannot do. Category 1, 2, and 3. And 3 will be things like neurosurgery or something really invasive, and 1 will be those things that the houseman will do, like CBD insertion and taking blood and all that. And 2 will be, in fact, most of the general surgery fall under 2. And in that guideline, it states that a person who is HIV positive is on ART and with undetectable viral load and on supervision by an ID physician and certified to be undetectable, can do procedures in category 1 and 2, right? So that is so far the practice here, or rather the guideline that we have.
So perhaps, James, I can chime in there. There is a very, very newly approved updated guidelines to the MMC. I'm not sure if MMC has actually made this public, but it's been quite a while in the making. It was put together by a number of people, a number of from the HIV, from MASHM, and we also work together with the Gastro Society. So it's new guidelines, not just for HIV, but for viral hepatitis as well. So I actually haven't checked if it's on the MMC website, but I believe it's.
Yeah, but I was aware that there is an update. I haven't got the new.
So it just that's why I don't know if it's on the MMC website, but because I was on the committee, I received news that it's been approved. Basically, really what you said, James, in terms of if a person is undetectable, it depends on whether you are doing what's called exposure-prone procedures or non-exposure-prone procedures. So exposure-prone procedures are like cardiothoracic surgery, most gynae operations where you can't see where your hands are. So there's restrictions there, but otherwise, most medical students, housemen, doctors, surgeons in training should be able to continue to work. However, they need to undergo supervision and also fitness to practice from the committee at MMC. So whoever is the treating physician should really get them assessed in the fitness to practice committee. And then there really should not be a reason why doctors can't continue to work if they are HIV positive and have an undetectable viral level.
Yes. Thanks, Prof. So I'll just move on to a question by Mark. This is on PREP again, not the topic here, but it says where are the indications? What are the indications to recommend PREP to a patient? Is PREP widely available? Maybe I'll answer the second question first. PREP is not widely available, at least for a community, but it is not widely available. There are only very selected places, especially in Klang Valley and in Penang, that I'm aware of, that will offer PREP in the community. One of my so far unfulfilled bucket list is to start the PREP clinic in my own setting. So that answers your first question. It is not really widely available, although I would wish it to be, right? For those uninitiated, PREP means pre-exposure prophylaxis. That means we give medication, in this case, Truada, medication, a combination to a HIV negative person who has a risk of getting HIV, either usually through sex, and who do we recommend to? There are a lot of criteria, terms and conditions, probably quite beyond the scope of this forum. But briefly, if a person really has risk of getting the HIV, then I would recommend for them to be on pre-IUP or PrEP. Right, so I can't really go further than that without going to.
Maybe we can get Academy of Medicine to host another session on PrEP, and I can think of a few people who'll be willing to do that.
Definitely, yeah.
It is a shame that PrEP is not more widely available, because it really is quite inexpensive now. It's about, I think,
again,
less
the
than 100 ringgit a month. Pardon?
Again, the evidence for PrEP is very strong. And
yes, very, very strong. Yeah, we can do something similar for that. So James, there's more questions on serodiscordant couple.
Do they need to take prophylaxis even though the couple is negative?
And also one on sperm washing.
Yeah, I've heard that term for a long time. So in my practice, I don't give PrEP to the negative couple, because I truly believe the science behind it, and so far my practice has been validated in so many years. I've run the clinic for 20 years, and the couple, none of the negative partner is ever infected, and they have children, 2 or 3 children, not. And so yeah, I don't give prophylaxis to the negative couple, provided the HIV partner is on ART and undetectable. Yeah. So sperm washing, yeah, I've not heard of this term for the longest time. I think one is very, very expensive, and 2, not widely available in Malaysia. I think we have now so much better strategy.